respiratory emergencies. Just a little review, anatomy and physiology, diagram of your lungs. So your lungs are surrounded by these pleura. The visceral pleura is kind of wrapping your lungs, and you can think of that as around the organs, versus your parietal pleura, which is the lining of the inside of the chest cavity more. The rest of that I think we talked about at some point. This we've gone over a few times. Anyway, so which one is the active process? Inspiration is the active process. Expiration is passive. Again, it takes all these muscles working together, expand the size of your chest to pull air in. And then all those muscles relax, chest gets smaller, air goes out. If you're breathing adequately, then you're a happy camper, and you're going to keep on living, indefinitely. So signs, symptoms of adequate breathing versus inadequate. Adequate breathing, no apparent obvious distress. Whoever you're talking to can speak in full sentences. Good skin color, normal mental status. They're all oriented and responding appropriately. So normal rates. An adult, you're looking at 12 to 20. A child, 15 to 30. And an infant's more like 25 to 50. So you can break this down quite a bit more for different age ranges. But this is about what you should memorize. When we start dealing with pediatrics, we start using field references, basically, little cheat sheets, to get us a little bit more closer in on the vital ranges for a particular patient. Besides being within normal limits, you want their breathing to be regular, so just in, out, in, out, in, out, nice and regular pattern, not like 5 quick breaths and then nothing, and 5 quick breaths and nothing, or something like that. When you stick a stethoscope on their chest, you should be able to hear some breath sounds on both sides, and you should be able to hear equally on both sides. Breath sounds are not overly loud, so in environments like the back of an ambulance, they're kind of hard to hear. It's usually a good idea to listen when you're on scene before you get in the back of the ambulance. If you're having trouble hearing the breath sounds, you can tell the patient to breathe in through their mouth. That usually helps to increase the sound a little bit. So that was adequate breathing. Then we move on to inadequate breathing. So this is where you don't want to have your patient be. So this is breathing that is not sufficient to support life. Some things you're looking for, rates outside the normal range. So both too fast and too slow are not good. Irregular rhythms like gasping, that kind of thing, agonal breaths is not good. If they're breathing but you don't really hear anything on one side or the other, or they're not breathing deeply enough that you can't hear it fully, so diminished or absent. Kind of right along with that, they're not moving enough air, poor tidal volume. These are all signs of inadequate breathing. In infants and children, you can add nasal flaring, grunting thing. Seesaw breathing, which is kind of where they are using their abdomen a lot, so it looks like one side's going up and the other side's going down like this. And then your retractions, substernal retractions. Grunting is this effect where the kids are trying to not let their lungs all the way deflate. And so they're kind of keeping a little breath in, making a more grunty sound. I'll see if I can find a video for you. A little clicker. Okay, so how many for A, B, C, D, yeah, so proportionally larger tongues, that's the only one of those that's accurate. Okay, so if you decide your patient has inadequate breathing, we need to fix that, because inadequate breathing, again, not compatible with living. So, ways we can fix that. If you don't have a bag valve mask, you can use a pocket mask, preferably with supplemental oxygen. Not all pocket masks have that little oxygen port, but if it does have a little oxygen port, you hook up your oxygen, and what do you run that tank at? Anybody? What's the flow rate?
12 to 15.
Just 15. Yep. So if you want to memorize that, whenever your patient is essentially circling the drain, dying on you, it's always 15. So BVM, pocket mask, or just 15. No rate or no range in there, just 15. So pocket mask. If you've got a BVM, that's going to be our preferred tool. And again, these patients are not necessarily not breathing at all. We can assist their breathing. Yeah.
Okay, so you just said the BVM was preferred. Reading the textbook, I don't know, things could have changed by then, but just to clarify, it does say in the textbook that the pocket mask, face mask, is preferred over like the BVM.
For a single rescuer,
Okay.
and when your patient is like not breathing,
Okay.
yes, you can use a pocket mask. If you have a BVM, that's going to be your best bet, especially if you're assisting somebody breathing, because remember, a pocket mask is you kind of right there on their face, and yeah, that's going to work a lot better with a bag valve mask versus your pocket masks. And finally, you can have kind of these oxygen-powered ventilators, auto vents. So these are applicable when your patient is not breathing at all. These aren't going to be what you want to use for patients that are breathing somewhat on their own, but you're supplementing. Just because they don't necessarily give the breath at the right time. It's when somebody's breathing on your own, you can't fight them with your bag and push air in when they're trying to breathe out, kind of thing. You got to time it. You can sometimes give extra breaths in there, but so then once you've decided you're going to assist their respirations, you can do that well and it can be adequate, or you can do that poorly and it can be inadequate. So when you're assisting with ventilations, you need to make sure you get chest rise with each breath, and you need to breathe at the right rate. So for adults, we're going to breathe at 10 to 12 breaths a minute. That's one every 5 to 6 seconds versus one every 3 to 5 seconds for infants and children. And actually the infants and children guideline is going more to that faster end now, so like 1 every 3 seconds. So for adults, if you find an increasing pulse rate, that can be a sign that they're compensating more than they should be. And so that can be a sign of inadequate artificial ventilation. So like a fight or flight kind of response versus in kids, their oxygenation kind of dictates their pulse rate a little bit. So when they start getting low oxygen, their pulse starts going down. And as you reoxygenate them, their pulse starts going back up. So it's kind of an inverse relationship for adults. But for kids, if you see bradycardias or low heart rates, think airway or oxygen. Okay, breathing difficulty. So this is a pretty common complaint that we get dispatched for. If you walk in this room, see this gentleman sitting there, what's kind of your general impression? Not really being able to hear him, but just from appearance-wise, how does he look?
Looks like he's kind of in respiratory distress.
Why do you say that?
He's sitting in that like kind of tripod position.
Yeah,
His
he's
skin color
leaned
doesn't
over.
look quite normal. I mean, he's probably already a little bit wrinkly, but his forehead is creased like he's concerned.
He doesn't have a super happy expression. His skin color looks okay to me.
Sweaty.
He looks kind of purple.
He's a little bit diaphoretic. He's a little sweaty.
Looks like he might be breathing with his mouth open instead of through his nose.
Yeah. So again, breathing difficulty is their perception. So they just feel like they can't catch their breath. Sometimes people kind of get a little more anxious than their condition warrants, so they might feel more distress more distress than is, I shouldn't say appropriate, but more distress than what would reflect their real severity. When we document this, it's dyspnea, difficulty breathing. So what about your whiteboards again? Go through our OPQRST questions. Yeah, so there's some of those old things. Okay, things to look for. Altered mental status. So remember, your brain needs a lot of oxygen. And if you start getting hypoxic a little bit, you are going to probably see some mental changes. Sometimes they're going to be hard to detect. Unusual anatomies, so like big barrel chests, people that are working hard to breathe, kind of constantly get that way. Look how they're sitting, tripod, leaned over, their hands on their knees. Look at how hard they're working to breathe. You noticing any substernal retractions, spaces in between their ribs. Flared nostrils, especially in kids. Pursed lips is kind of related to that grunting sound of breathing, where the patient is trying to not let out all of their breath to kind of keep those little alveoli open. Usually that's a sign that there's some fluid or gunk down there, or that their elasticity in those little alveoli is decreased, and they're trying to keep them open that way. Look at the number of words that they can say without stopping. And you can say that's X word dyspnea. So if they can get out 3 words before having to take a big breath in, then that's 3-word dyspnea, that kind of thing. If they can only say 1 word in between taking a big old breath, then that would be 1-word dyspnea. Look for pale or cyanotic or flushed skin. So pale skin is what you expect when you're getting that fight or flight kind of response, right? And you get peripheral vasoconstriction versus the cyanotic or more bluish skin, which is when you're still getting circulation into your skin, but that blood isn't as oxygenated as it should be. And so you get more of a bluish tint to the blood instead of the pinkish tint. Your flush skin, you sometimes see somebody's hyperventilating, they're getting enough oxygen, right? But hyperventilating causes other issues. You can have real flush skin. Edema is in places where they shouldn't have edema, so what is edema? Anybody?
Collection of fluid.
Right, so it's fluid where it shouldn't be. So fetal edema, what that looks like is big swollen feet, swollen ankles, versus sacral edema around this area. And usually what that's a problem or a sign of is some circulatory issues. And those circulatory issues often manifest in edemas also in the lungs, which you can't see. Coughing, sign of some extra mucus in the airway, or maybe a foreign body obstruction. So leaning over, straining intercostal muscles. See that. Flaring nostrils you'll sometimes see in adults. Various different lung sounds. Talk about that a bit. So normal breathing is just a nice kind of whoosh of air in and out, right? And so you should listen to lung sounds on all your patients if at all possible. That way you know what normal sounds like, so that when you hear something out of the normal, you can identify it. So things like wheezing, usually you can hear that without a stethoscope, so that kind of thing where they're pulling air in. Most wheezing is on the expiratory phase. And that's that kind of high-pitched whistly sound versus gurgling like they're breathing through fluid, snoring like their tongue's getting in the way. crowing, kind of a coffee, barky sound. And stridor, which is the upper airway obstruction, and that's a whistly sound, kind of similar to wheezing, but it's coming from the upper airway. And that's the sign of a upper airway obstruction, some kind of foreign body up there usually. So listen to lung sounds on both sides. You listen on the same place on both sides. So if you're listening, here and here, then listen here and here. If you listen more on the fronts, that's fine. You can listen in the back too. So again, a little more description here. Wheezing, that high-pitched, kind of whistly sound. Crackles, some kind of finish fluid, thinner fluid, kind of in your lower airways. Bronchi is kind of a more thick, chunky sound. And then your stridor is that high-pitched, wheezy, whistly sound. It usually means there's something obstructing their upper airway. When we get into crackles versus bronchi, we usually just kind of document that as like wet lung sounds when you hear something bubbly, gurgly in there. You can get pretty specific as to crackles and bronchi and other ways to describe lung sounds, but wet or it's usually good enough. Other vital signs to check for, again, increased or decreased pulse rate. Look for your little SpO2 meter and what it's reading. That'll be your oxygen saturation. Obviously, you're going to pay attention to breathing rate and rhythm, and what their blood pressure is. Okay, so kind of your steps of patient care here. Make sure that they're breathing adequately. If they're not moving enough air, either by rate, volume, or whatever, then we start helping them, and they don't have to be passed out dying, like not breathing at all, before we whip out our bag valve mask. So you can assist these patients to breathe while they're still breathing. If they're moving adequate air, then you can use a non-rebreather mask. If you're looking at your little pulse oximeter guy here, and they're complaining of breathing difficulty, but their O2, saturations are mid to upper 90s, then you'd actually probably start with a cannula here. Give them a little bit. You still give them some oxygen, but give them perhaps a little bit less oxygen. Put them in position of comfort. Start thinking about prescribed inhaler. If they have an inhaler prescribed to them already. CPAP in some places. We don't do CPAP here at our EMT level. Some places have started to allow that. So what CPAP does is it keeps some pressure in the lungs, keeps those alveoli open. This is getting more and more common. People prescribe this for like sleep apnea and stuff like that, CPAP machines. preventing these alveoli from collapsing. Most of the CPAP machines that you'll find in people's homes don't use supplementary oxygen. There's no reason they can't. At least the sleep apnea ones don't have supplemental oxygen with them. Other things they're used for: pulmonary edema, long-term or more longer-term care of drowning patients, chronic obstructive pulmonary disease, just patients that kind of chronically have a hard time breathing will get prescribed a CPAP machine. Okay, so let's talk about a few specific diseases that could cause somebody to have a breathing difficulty complaint. COPD is the first one we're going to hit, and this is actually a few different diseases. So your emphysema, chronic bronchitis, and black lung. Most of these cases are caused by long-term smoking cigarettes. But the diseases basically just fit this pattern of chronic, so long-term, obstructive, so something getting in the way of their airway, pulmonary disease. So for chronic bronchitis, so this is a long-term infection of your bronchi, or an inflammation of your bronchi. So when they're inflamed, you get excess mucus in there, and the little cilia that are in your airway, and usually you're able to move that mucus up so you can cough it up or spit it up. There's too much mucus, and you get mucus in your lower airways. And stuff just generally gummed up. So inflamed bronchial and excess mucus. So when you have excess mucus down here, then you're not getting as good oxygen exchange. These patients kind of have chronic issues with O2 saturation and stuff. That's another one of these COPD diseases is emphysema. So in this one, your alveoli become less elastic, and they don't stay open as well, and so these little grapey looking clusters can go flat instead of staying open. And sometimes that leads to air being trapped in there. You can also have some of that mucus stuff going on. Then the black lung deal, we don't have the coal mines directly here, but that's how you get black lung, was working in a coal mine without proper protection of your airway. That was the COPD things. Moving on to asthma. This is a pretty common disease. I bet you everybody in here probably knows somebody at least that had asthma. If you haven't experienced it yourself. So this is a kind of a chronic long-term disease where you get individual cases of it where they're more severe, right? An asthma attack. So during an asthma attack, you'll bronchioles kind of constrict, you get that bronchoconstriction, you get excess mucus, and stuff gets plugged up. When you're breathing in, you kind of expand those tubes on your bronchi and bronchioles. And so you can kind of pull air in, and then as you're breathing out, you have a hard time pushing that air back out. Everything's collapsing. You get that expiratory wheezes. Feel like you can't catch your breath, then you can usually pull air in, but breathing it out is the wheeze, and you get the wheezes. Yeah, so you get bronchoconstriction, excess mucus. So which of these that we've talked about are you going to give oxygen for? All the above. Yeah, do you have a question? Yeah. So, it's been a long time probably now, but we used to teach you be careful about giving oxygen with the COPD ones, chronic bronchitis and emphysema, because these patients have kind of chronic hypoxia, and so there was this worry that you give them a whole bunch of oxygen and then their body systems they're gonna think don't need to breathe much anymore, basically was the idea, and that you stop them breathing by giving them too much oxygen. It was basically wildly overblown, but EMTs were taking home the message that you shouldn't give oxygen to people with COPD, and that's not the case. These people can all have oxygen. Again, we're gonna, in general, use our pulse oximeter and titrate to effect, but especially people complaining of breathing difficulty, you can give them a little extra oxygen. It's not going to hurt them. Okay. Moving along here, pulmonary edema. So this would be excess fluid, that's the edema stuff, into the lungs. So on an X-ray like this, fluid is going to show up as the white stuff here. Normally your lungs are pretty clear to an X-ray. Usually this is a result of some issue with your heart, so a congestive heart failure kind of issue. So when one part of your heart is working better than the other part, you can get pressure building up where it shouldn't. So like if your left ventricle especially is had an MI or is failing in some way, and your right ventricle is working great, you get great blood pressure into your lungs, but then it starts backing up when it's coming through to go to your body through the left ventricle, and so that fluid can build up in your lungs basically. And when you get fluid in those alveoli, you don't get good gas exchange. So common signs and symptoms of pulmonary edema. The breathing difficulty, they're not going to be feeling well, anxious, pale, sweaty, heart's going to be racing, usually hypertensive, low oxygen saturation. What else? What else might you notice if they've got fluid in their lungs?
Sounds.
Yeah, good. Wet breath sounds. So you're going to hear some kind of crackles, wheezes, something. Their lung sounds aren't going to be normal. They might be coughing up sputum, frothy looking stuff, so not like mucus, but bubbly looking stuff. So what are you gonna do for them? You're gonna make sure they're breathing all right. If they're not moving enough air, you're gonna assist their respirations. You give them high concentration oxygen. So if they are breathing enough volume on their own, then non-rebreather, cannula. If jurisdiction allows, maybe CPAP. These patients, you want to keep them sitting up. You get all that fluid in the lungs, it'll kind of stay in the bottom of their lungs. When you start laying these patients down, that fluid goes different places and it can obstruct new areas in their lungs. So these patients especially, you don't want to lay them down. So at least in a Fowler's position, if not, sitting up a little bit more is where they're going to be more comfortable. Our stretchers don't really have a little thing for this dependent position where they can push off of something, but if you find yourself the ability to do that, that's fine. So we're going to skip this one. She doesn't count very well, but the basic idea here is that if one side of your heart's working good, then whatever's receiving the blood from that side is going to have higher pressure, and then if it comes around to the other side that's not working so good, fluid's going to back up there. So if your right ventricle is working well, you're going to get good high pressure blood to your lungs, and if your left ventricle can't keep up, fluid's going to back up in your lungs. And then if the opposite occurs, if your right ventricle isn't doing so well, but your left is, then you're going to get fluid building up more in bodily tissues and stuff. It's going to, if that makes sense. Pneumonia, so this is a kind of a broad term. So this is any infections in the lungs caused by bacteria, viruses, or fungi. So your lungs present a nice, warm, moist environment for things to grow. And there's actually, at any one given time, probably lots of things growing in everybody's lungs. It's just when they get out of control, we get the pneumonia. So signs, symptoms here, shortness of breath or breathing difficulty, with or without exertion, coughing, we cough up mucus and stuff, fever and or chills. This is the way you're going to distinguish this one from something like pulmonary edema most of the time. They'll have some chest pain perhaps. Headaches, maybe pale, sweaty skin, fatigue, confusion, a lot of these kind of generic signs, symptoms. Again, the way you'll distinguish pneumonia from some other things is this fever. Your body's fighting off an infection. Treatment for pneumonia, you're not going to cure the pneumonia, obviously. You're not going to give them antibiotics and stuff. So just make sure they're moving adequate air, give them oxygen, transport. Spontaneous pneumothorax. So A pneumothorax is when air gets in between your lung and thoracic cavity, your chest wall, and the air starts collapsing your lungs. So occasionally these things happen without traumatic injury. Most of the time when we see a pneumothorax, it's due to some kind of trauma, either penetrating trauma to the lungs or some non-penetrating traumas. For the spontaneous ones that just occur out of the blue, for some reason, tall, thin people and smokers are more high at risk. So, in this X-ray, you can see normal lung tissue-ish over there, and this side is all filled with air, and this is the edge of the lung that's collapsing in here. So this isn't something that you can see, obviously. You can't be out there with your X-ray machine. So signs, symptoms. You'll have some chest pain on the side that's being collapsed. You should have absent or decreased lung sounds. If you do a little tap, 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 it'll actually sound more hollow than the other side. They'll have shortness of breath, breathing difficulty, low oxygen sats, cyanosis, fast heart rate. Mostly the distinguishing characteristic of this one is that decreased lung sounds on one side only. Treatment here is going to be rapid transport. These patients don't last particularly long with a pneumothorax, depending on how bad it is. If you give them oxygen, make sure whatever air they are getting is fully oxygenated. You would not want to do CPAP. Increased pressure is going to make more air go out of that little hole in their lungs, and it's going to collapse the rest of their lungs faster. What these patients need is a little hole through the outside of their chest wall to relieve that pressure, relieve the air. So they need a chest tube, or paramedics in the field can do needle chest decompression. But rapid transport for sure. Next one, pulmonary embolism. So this one is less a lung problem. This one is a problem in your circulatory system. So what'll often happen is you'll get broken bone, or just be sedentary more than is healthy, so like long airplane flights, that kind of thing. And you'll get these little thromboses build up in your deep veins, these DVTs. A little thrombosis is a little blood clot. You get your blood pooling because it's not moving enough. A little thrombosis starts moving around in your vasculature, and if it gets up here, it gets through your heart, and then gets into one of these little bitty capillaries in your lungs, and then lodges. And you've got that whole little bit of lung that's not doing gas exchange anymore. There's not getting any blood to it. So signs and symptoms are going to be chest pain, shortness of breath, low O2 sats, cyanosis, tachycardia, wheezing. Pretty similar to a lot of other breathing difficulty calls. Your history might lead you to think PE. So if they've had some recent surgeries or were bedbound for a while, that kind of thing, you might think DVTs. But in general, it's pretty difficult to differentiate. And our care really isn't that much different than other things, just transport, give them oxygen. Next one, epiglottitis. So remember, your epiglottis is that little flap of skin that covers the entrance to your airway. So what you're looking at here is your vocal folds, and right through there is your trachea. This down here is your esophagus. So if this little flap, that's this thing here, if your epiglottis gets all swollen and inflamed, it can get big enough that it obstructs your airway and you can't move air past it anymore. So signs, symptoms, sore throat, drooling, difficulty swallowing, painful to swallow stuff. You're going to be upright in tripod, look pretty sick. They're going to have a hard time being heard. They're going to have a muffled voice. Because again, that big inflamed epiglottis is sitting right above their vocal folds. That's what that is right there. It's their vocal folds. They've got an infection and inflammation, so they're probably going to be running a fever. And you might hear stridor. Usually get that upper airway kind of obstruction. Treatment here, try and keep them calm. You don't want to be poking anything close to that epiglottitis. You want to poke anything near it. If you start getting anything down there by that epiglottis, you start putting stuff in their mouth, that thing can spasm closed. Give them some oxygen, as long as it doesn't freak them out too much. Transport. Cystic fibrosis. So this one is a genetic disease. So this isn't something you catch, this is something you're born with. Basically it's excess mucus in your lungs and digestive system. Because there's too much mucus, your lungs don't clear it out as well as it should. And so you get long-term infections and issues with that. So signs, symptoms, a lot of your standard breathing difficulty ones, but they're going to be coughing up mucus, general fatigue. They'll have histories of pneumonias, perhaps coughing up blood, abdominal pain, general nausea, weight loss. Again, this is something that somebody's born with, and the parent of that, usually child, is going to know a lot more about this than you will. And so they can tell you, what's normal for that patient, what they need help with, whether you should give oxygen, that kind of thing. If you got low SpO2, go ahead and give oxygen. Otherwise, more or less, you need to just transport, get that kid to the hospital. Other viral respiratory infections. So think, colds, influenzas, that kind of thing. Most of the time, these aren't serious for healthy adults. Patients that have chronic diseases like COPD, you throw in a particularly bad bout of the flu or pneumonias, other stuff. Have bad outcomes. So I'm sure everybody's probably experienced things like this once in a while. Fevers, coughs, colds. Okay, what are you going to do about these things? So again, if a patient is prescribed an inhaler, so this isn't a medication that we carry around on the ambulance. You only get to give albuterol if the patient has it and it's their own medication. But we can assist patients with it, basically. So the dose is one little puff. That little inhaler device squirts out the right amount every time you push on it. Remember to check your rights, patient medication dose, route, time. Shake that thing up, get the medication mixed. Make sure your patient is alert enough. You can't give this to a patient that's unconscious. They would be able to breathe in at the right time when you say it to breathe in. If they have a spacer device, that's a good thing to use. So that's this guy here. And basically it allows the medication to get aerosolized instead of just ending up on the back of their throat. They need to breathe this stuff down into their lungs. And so if you can use one of these little spacers, then the medication gets into the air and they breathe the air in, right? Versus you gotta time it just right when they're breathing in, so that when they're sucking a breath in, and then you pump this little inhaler, and then hopefully it gets into the air as they're breathing it in. So again, they're gonna breathe out, and you put that little thing in their mouth as they're inhaling, and you give a little puff of the thing, and then have them try and hold that in their lungs as long as they can so that the medication sits in there and works. Realistically, I've never actually assisted a patient with one of these things because they know they have them and they've usually puffed on that thing about 100 times and it hasn't worked, and that's why they called us. So what medics can do is give nebulized albuterol, which is basically just like a constant breathing a mist of albuterol in. That can do pretty good for the patients, and it's a little more effective than the inhaler type. But you never know. You might end up with a patient that just forgot they had an inhaler and wants you to help them use it. So. Questions on that? Anything in general?